Assalamu alaikum wa barakatuh. Thank you, Dr. Ihab, for the introduction. Thank you, Dr. Askar, the scientific committee and the organizers for having me today. I'll try to keep everybody awake after lunch break by talking about such a dreadful disease, Richter transformation. These are my disclosures. So we know that Richter transformation or Richter syndrome is a consequential condition. Thankfully, it's infrequent. It will happen in patients with prior history of CLL or SLL. It's an aggressive lymphoma. It was first described in 1928 by Maurice Richter, hence the name. And most commonly, patients will develop the diffuse large B-cell lymphoma variant, like more than 90% of the cases, as you see here in the figure. A little around 10% will develop Hodgkin lymphoma variant, but there are also rare cases of other variants, like histiocytic sarcoma variants they are reporting. Majority of the literature about this condition and how to manage is driven by the diffuse large B-cell lymphoma variant. You can see here on the right side of the screen that majority of the cases will actually be almost more than 2/3 of the cases will be clone related from a prior CLL or SLL. The remaining will be de novo, so both conditions are happening without any clonal relation. As I said, it's thankfully that this condition is indeed infrequent, with an estimated annual incidence of around 1%, overall prevalence of around 10%. So these are the established risk factors that have been reported. Should they happen in these CLL, SLL conditions, patients are more likely to have Richter transformation at some point. So most important, if you look here, it's more about the bulk or the burden of the CLL, but also more important about the biology of the disease. I don't know if you're familiar with the stereotype B-cell receptor. So they have done a lot of studies on the type of the IGHV mutation, and they subcategorize patients into different subset. This special variant gene is called subset 8, and when this actually present, it increases the odds of developing Richter syndrome. Of course, CLL, SLL cases who actually harbor 17p deletion or TP53 are more likely to develop Richter transformation. Overall, regardless of what they're actually been exposed to, because these are the initial notion that exposure to certain therapy may hasten the transformation. This is actually have been proven wrong in the recent literature. So you're talking about an average time from diagnosis to disease of around 2 years for the large B-cell lymphoma variant, and around 6 years for the Hodgkin lymphoma variant. So this is a study that actually took CLL cases and analyzed Richter transformation timing, like can we actually see how soon this can actually happen in the presence of certain mutations. And they found the most likely mutation that will accelerate transformation to Richter or syndrome is if the patient or the disease harbor complex karyotype, at least 3 big or significant aberrations. You're looking at around 30% risk of transformation by 10 years. When would you suspect Richter in your patient? If he or she is already on therapy and then suddenly the lymph nodes are enlarging, or you're seeing discordant response or progression, development of constitutional symptoms, which is not typical for CLL patient, rising LDH, and this disease tends to cause extranodal. I'll show you a very interesting picture of a published case where it can actually be, and of course, as the disease progresses within the bone marrow, those patients are expected to have worsening anemia and thrombocytopenia. PET-CT is very useful in Richter. It actually can help guide the diagnosis. So it shouldn't be relied on to diagnose the disease. You still have to get a tissue biopsy, but at least you should get it from where the disease is highly active. Like, for example, in a large meta-analysis, they have shown that if the SUV max at least 5 or more, it has an around 85% sensitivity for Richter transformation. But this is, again, this meta-analysis included cases even from the chemoimmunotherapy era, because we have to remember that with the more targeted therapy, when the disease progresses, it can actually cause rise in SUV max. So that sensitivity will go lower. If that patient was exposed, for example, to BTK inhibitor, it could actually cause a higher SUV max. So still biopsy is the most important guidance. So these are two cases. One is presenting concurrently here in figure A, and the other one is later on. You can see the difference in the SUV uptake between where the transformation is most likely happening and versus the left axillary lymph node. So generally speaking, when the clinical picture fits the phenotype and the laboratory derangement is actually happening, it's important to use the guidance of PET-CT. Studies have shown even if the SUV max is even exceeding 10, it's very highly suggestive, but it has to be at least more than 5, because less than 5, majority of case reports are saying it's unlikely for this to be Richter, but whether or not you need to biopsy those patients, this is according to the clinical judgment. So once the biopsy is done, it should be guided by the most avid site, and then you go further with tissue confirmation and then overall evaluation and therapy after that. So whether it's exogenal or incisional, you should get enough tissue for the hematopathologist to make the right diagnosis, because there are actually studies that have shown discrepancy between the diagnosis and the histopathological conclusion. So you need to consult with expert pathologists, because, for example, CLL with enlarged proliferation center can look like Richter, so they have to be familiar with this. Like the most recent update are saying there has to be confluent of sheets of large cells. They look like centroblast or even immunoblast-like, so they have to look large enough and confluent enough. And then you would go with the immunohistochemistry findings, knowing that it is expected for them to lose CD20 if they've been exposed to anti-CD20 prior to that. It is also expected that the CD5 and CD23 would not be as avid as in CLL cases. Majority of them will have non-GCB-like if you use the Hans algorithm. And this is an important phenomena, which is withdrawal of BTK inhibitor, because if your patient has been on it, for some reason he or she stopped it, they can have manifestations that look like Richter, and reinstitution of BTK inhibitor can resolve this. So always rule this out for patients who are on BTK inhibitor. This is a peripheral blood showing combination of large cells and mature cells. Usually you would see this in advanced and sick patient. This is again the information I was alluding to, extranodal occurrence in the heart, so it can go anywhere. Out of the one of the largest studies that are giving us guidance on how would be the prognosis of those cases, they've looked at these factors, and absence of any of these factors may improve the overall survival. Again, that overall survival in that time was actually not optimum, but this is a good risk score you could use once the diagnosis is confirmed to know what type of disease you are dealing with. So, so this is a British group who put a proposed algorithm of how you would treat those cases. So after the diagnosis is confirmed and you've done the necessary molecular studies, majority of patients, if not all of them, will receive R-CHOP-like therapy. You may consider observing rare cases who are actually CLL treatment naive, who achieved metabolic response. However, this is very rare, as majority of them will be patients who had prior CLL therapy, patients who had TP53 mutation, and more important, if you have access to a testing for clonal relation, there will be clonally related. Those are the ones you should consolidate with stem cell transplantation. Allo versus auto, I don't think there's any major difference. It's a case by case, of course. And then in relapse cases, clinical trial should also be the option from the get-go, as it's stated there. But relapse cases usually will have much more dismal outcomes. But whenever there is any hint of any response, consolidation with stem cell transplant is a key. I'll take you through the findings of this final conclusion of how you would approach those cases, because we need to know currently, not in the before, like in the older era, in the current era, which is this, and this is a recently published paper, how are those patients behaving when they are diagnosed with Richter. So they divided this group into concurrent diagnosis of CLL and Richter, and then if it's not concurrent, have they had prior therapy or not? So this is the blue and the green and the red. You can actually see the differences in their survival, but I just summarized to you some of the important findings, which goes along with what we have discussed so far. Majority of them will come with an FDG-avid PET-CT, higher LD. More than 2/3 of the cases are non-GCB-like. And despite these centers had access to clonal relation or relatedness, only 90 patients were tested for that. And I'll show you the benefit of this in the current era, how these two groups would respond to therapy. This is the number I want you to remember, that you're looking with maximum supportive therapy, early diagnosis, R-CHOP-like therapy. This is the median PFS we could achieve overall. It will be much more shorter in aggressive form of the disease, and maybe similar or longer in the most benign presentation of the disease. But again, overall survival will be different and will be even worse for the cases who actually had treatment for CLL, especially if they've been exposed to a BTK inhibitor. This is how clonal relation is a key. I know some of you, if not all, would always like to test their patients for this, and that information is true, because if they're not related, they actually will behave similar to de novo large B-cell lymphoma. So we know that with R-CHOP-like regimen, you're looking at an overall response rate in the vicinity of 40%. So would you actually use higher dose chemotherapy? Is that actually going to make any difference? So this group, they have done both. They started with the higher dose regimen first, but their take-home message is addition of novel agent, how the addition of novel agent will do to this. And again, the studies I'm going to show you, you're not going to look at importance of a p-value. They're all phase 2 studies, because this is a rare condition and it's very hard to do randomized study. It will take time to complete this. So this is the characteristics. I'm actually standing. I don't know if you can actually see this, but so those patients had, majority of them, they had prior therapy, complex karyotype. They've been exposed to BTK inhibitor and even venetoclax. So what they have done for those patients, basically, they will debulk the disease with one cycle of R-epoch, and then they will do an accelerated venetoclax ramp-up over 5 days. And then after 24 hours, they will resume therapy. They will do an assessment after, or they did an assessment after 3 cycles, and their intention is whenever there is a response, they will take that patient to stem cell transplant as early as 3 cycles. If there is no response, they will continue with an additional 3 cycles. The mean number of cycles those patients were able to receive was only 5. But the take-home message from the design of this study, they implemented venetoclax maintenance, which I think this is the reason why you're seeing a plateau after lots of patients succumb to the disease or to the complication of the disease. You can see here in the safety profile, lots of patients had neutropenia and febrile neutropenia, including infections. But generally speaking, if this regimen is tolerated, it has achieved deeper response measured by undetectable MRD. And with the addition of maintenance, maybe you can actually sustain that response, especially in the ones who cannot go for allotransplantation. So again, as I told you, this group, they tried to see, okay, what if we de-intensify? Can we back up and do use R-CHOP again, but we will add venetoclax to it? It's the same design, except that now they're using R-CHOP. You can actually see, I'm going to take you to the next slide easier. You can actually see they have achieved similar responses. So again, it's a similar patient phenotype between the two studies. They were not comparing, they're just showing you the summary. This one with the VR CHOP is still ongoing. The VR epoch has already been published. And you can see the CR rate between the two groups are actually similar. In fact, this is a record CR rate. You don't actually achieve that CR rate with R-CHOP alone. And then this translated in an impressive overall response rate of around 70%. But you can actually see, even with the higher dose regimen, because this is still ongoing, there are cases who actually develop disease progression or relapse, and there are some of them who actually died from complication of transplant also. So this is considered a concerning number of deaths overall, but if that patient is young and fit, maybe this is an okay regimen. Otherwise, we're all keen to see what will be the overall conclusion of this study. Expectedly, as I said earlier, more toxicity with higher dose chemotherapy. So what is the role of PD-1 in CLL? So this group has done a very interesting analysis of Richter transformation cases, and they were able to show, in fact, that PD-1 is expressed in those cases, which is against what you would expect in biology. Because when you talk about PD-1, this is mainly on the T cells. So how come the B cells are doing this? So Richter is another malignancy who can actually express PD-1. And they have shown the more aggressive the disease, the higher the intensity of PD-1 expression. So their actually theory here is that maybe Richter transformation cells, they behave like B regulatory cells, which they do upregulate PD-1, and this is how they can evade anti-tumor immune response by interacting with macrophages who would express the ligand for PD-1. With this, people got excited and they did a study. So this is a study that was sponsored by B1 using a PD-1 inhibitor with zanubrutinib. This chart only for us to understand how those patients were enrolled. Those are heavily pretreated patients who even some of them had allotransplantation prior. They went on to receive this combination. And yeah, this is just a summary. If that figure was very hard for you to see, again, what we would expect in those cases, most of them had 17p or TP53 mutations. Majority were unmutated, higher CLL-IPI risk score, a lot of complex karyotype, and as I said, majority of those patients were actually treated for Richter prior to this. Which is summarized in the next slide. So some of those patients had chemoimmunotherapy prior to the trial. Some of them had targeted therapy, and that targeted therapy can be BTK or BCL2 or even the combination of both of them for CLL, and 20% of them were already treated for Richter, and this is now a relapse of Richter, so heavily pretreated. Despite this, you're actually still achieving an overall response of around 60%. But again, sample size is small. They were trying to show here that if they were BTK naive, they may actually have a better PFS. Remember the number I told you, the PFS we're hoping to achieve is around 24 months. So they achieved almost half of that as a second line therapy. So maybe a chemotherapy-free regimen can be an option in patients who cannot tolerate chemotherapy with good response rate that can hopefully bridge those patients to either maintenance therapy or stem cell transplantation. Why stem cell transplantation is important? This is a very aggressive disease. You cannot kill it from only 6 cycles of chemotherapy, so you have to consolidate. So this group analyzed the CIBMTR database for stem cell transplantation in Richter. Majority of the patients received allo. We all would advocate for allo from how we would think that disease would behave. They were arguing that auto was doing as good, if not even better, but the number of cases is less. And the allo patients had more bad mutations, received prior therapy. So maybe this is why when they did quasi comparison between the two, the auto was slightly better. But overall, the overall survival is similar between the two strategies. And because there was a lot in the allo arm, they were able to, or in the allo group, they were able to subcategorize them for us to understand that even with allo, you could proceed, or even with partial response, you could still proceed with allo and get a decent overall survival. But the patients who are actually achieving complete remission will have the most benefit of allo transplantation. More importantly here, regardless of the bad disease biology, presence of absence of 17p as an important example, it didn't even manifest into poor overall survival outcomes in this registry analysis. So in conclusion, Richter transformation or Richter syndrome, whichever you like to call it, especially the DLBCL variant, is an aggressive neoplasm. It continues to show with studies dismal outcomes. We're seeing now the inclusion of targeted therapy in treating this condition. There is an ongoing RCT, including acalabrutinib. We're all excited to see when it is a randomized study, are we going to see similar outcomes or better or even worse? It's important to promptly recognize these cases and diagnose them earlier on, so timely management can be entertained, because we've seen how poor the outcomes in those cases in the previous or older literature. I think with the coming few years, we will see targeted therapy becoming an important asset of the backbone therapy for Richter transformation. And until now, still, if you can get your patients to auto or allo, it's important, because this is how you can ensure durable response. Whether or not in cases who are not eligible, you should also consider the role of maintenance therapy. Thank you very much.